Um, Charles, I wanted to ask you a question, if that's okay.
Yeah, that's fine.
So I'm sorry if you already covered this. I just wanted to clarify. You mentioned the two different options for the pneumococcal new vaccines, PCV20 or the PCV15 followed by PCV23. Which is your preference?
Um, so we don't have them registered yet in South Africa. That's still due to come. And I'm hearing that maybe both of them will not be registered. The company have decided, South Africa is quite a small market. The cost is an issue. Everything we do, our work in the state sector, is cost related. It's not cost effective, it's the actual cost. So that would play a role. And that definitely makes a difference into what is put on the tender, so to speak, what is offered for the state sector. The one advantage about PCV20 is that it's one vaccine dose. Patients don't have to come back. And that's another issue. If patients are feeling well, they often don't come back for follow-up appointments. They've got to take a day's leave. They have to pay for the taxi to come into the hospital and all of that kind of thing. So if the cost's an issue, it will depend on which the cheaper one is. But of course, the one is two vaccines and the one is one. If it's convenience from the point of view of giving it at one sitting and that's it, it would seem to be PCV20. But those are the things that would come about. What about the studies? Do they help us? The efficacy studies. Well, the studies are all immunogenic studies, immunogenicity, non-inferiority. And the two vaccines, PCV15 and 20, for their vaccine serotypes that are contained, are very similar. There are slight differences, but whether the slight differences in immunogenicity make any difference to the clinical efficacy is probably unlikely. So both of them are good. Both of them are show good immunogenicity. They are non-inferior to PCV13, which is the gold standard, and it's had a clinical trial, the Capita study. So either of them, would be suitable with, just the issue of which is more expensive and which is more convenient.
I think they're not currently funded in Australia, but hopefully that will change.
They're not even registered yet in South Africa or licensed as such.
Thank you. I just want to thank the speakers, first of all. All your talks were wonderful. I want to thank our sponsors, Pfizer and Gilead tonight, and as well as thanking everyone for attending, both here in the room and online. So there was some, if I can share. So question for Anna. So you mentioned regarding bacterium tapering up regimen. What's your centre's protocol? Are there any risks for future bacterium resistance since early inadequate dose due to tapering?
So yeah, it's a good question. And actually our centre is currently developing this protocol because we've only really just realised the scale of the problem with tolerability. And there has been a randomised controlled trial published showing that stepping up the dose improves tolerability. So we don't yet have a protocol, but it will be something like 400 milligrams of the trimethoprim component BD for a day, and then 800 milligrams BD for a day for several days, and then the 1,600 milligrams BD thereafter. So just over it would probably be over about 6 days. We wouldn't be so concerned about resistance development because it's a fairly quick up taper. up titration, and also because there's another drug on board at that time, so the person would already be on their IV agent, be on the Keftaz or Meropenem as well.
Okay, and then there is another question that is probably also for you, Anna. Tuberculosis. So, what's your opinion on mandatory testing versus IGRA testing for healthcare workers for latent TB, and management of healthcare workers based on this result with background of high TB burden countries?
It's interesting how much this is still debated, and apparently at the International TB conference in Paris, that's just wrapped up, this was there's still debate about, who should you treat with that's got latent TB. Overall, my feeling is that if we're working towards a world where TB is eliminated as a public health problem, we should take every opportunity we can to treat infection, obviously weighing up the risk benefit. And I am sort of guided by the McGill calculator and other strategies to try to weigh up the risk of hepatotoxicity versus the risk of future TB, guided by things like time since likely exposure, whether the person has any immunosuppressive conditions and so forth. But I tend to be a fairly strong advocate to treat if infection is identified. And in terms of how, so look, I think either. In the Northern Territory, we often still do go with MAN2 testing in the first instance. And then if somebody's positive, if a healthcare provider is positive, often I will then recommend IGRA as a next step to try to ascertain, is that likely TB exposure? And if so, I would often be recommending treatment. I'm sure other people, there is a diversity of opinions here, and maybe some of the other speakers might like to add. Yeah, Charles, thank you.
I clearly am speaking from the South African point of view, which is very, very different. I mean, we have a massive TB problem in South Africa. And the problem is that all of us who have were born, have lived and are brought up in South Africa have probably been at some stage infected with TB. And in fact, if we had to do a MAN2 on most healthcare workers who have lived their lives in South Africa, you'll find that they are TB positive. So it's difficult. I know there are the criteria on size of the MAN2 response and that kind of thing. But in fact, in South Africa, it's not even recommended that that MAN2 testing is routinely done in adults who've grown up in South Africa. One of our residents, our registrars, was going to do a study looking at shift workers, healthcare workers doing shift, looking at non-communicable diseases and TB. And they played around with their MAN2 testing, and they tested each other. Now, these were healthcare workers born and brought up in South Africa, and they all came back positive. And they came to me and said, "What must I do now?" I said, "I don't know. Why did you test yourself in the first place?" There also, just to mention that there are two types of IGRA. I'm not an expert in the area. One sort of normalizes it to the number of lymphocytes, and the other one is irrelevant. And that's important because if you're going to do it in HIV positive individuals, it needs to be corrected for the lymphocyte count. Otherwise, it may not be that accurate. And in fact, our findings are that IGRA is about the same as a MAN2 test. So it's a difficult one because, just so many people would be MAN2 positive that, but this is a problem right through South Africa. In other words, TB is found in every single corner of the country at a very high rate. Our attack rate is very, very high. We tend to go the symptomatic route. If you're screening, start that way. And if there are certain select, screening things, but I'm sure it's very different to Australia. I mean, you've got focused areas rather than a massive epidemic right through the country.
Yeah, so certainly re-exposure in Australia is a much lower risk. And I suppose it's probably worth noting that definitely there's very good evidence that for children, in particular children under 5, there's no question that treatment is beneficial because of their much higher rates of progression, and in HIV positive people. But it's the older people, it's the adults, it's the other, the healthy looking adult that doesn't have HIV or diabetes or whatever that where the questions remain.
Yeah, we would agree with that, and there are recommendations for doing mantle testing in young children, because if they convert, they've had a recent infection. Whereas, as you say, in the adult population, I haven't had a mantle test for ages. I'm not sure what the value would be, just because so many of us would possibly come back positive. It's interesting seeing we're talking about it. It's always a problem for us when we get international medical students coming to South Africa who come to do electives in South Africa and run the risk of mantle conversion. We were faced by an American medical student who came out who was about to do her job at the Mass Gen, her internship, very prestigious internship. And she was a very bad asthmatic on high-dose inhaled steroids, and frequently needed a course of of oral steroids. And the question is, what should we do with her? Because she tested positive on return, she would have to go on to treatment and delay her internship. So we have those kind of issues. Those are real issues because, this is somebody coming from a low incidence area. But for the rest of us, it's very difficult to know. Obviously, in HIV, it is an important issue, but certainly I agree with you completely about kids as well. They are tested and it does have a relevance there.
Thank you. That was a great discussion. So I don't think there are any more questions. Just checking down. No, that's just the batching one. So this is the survey for anyone online who's able to complete it. And then I also wanted to highlight some upcoming CR events. So there's a OPAT/HIP masterclass coming up in February 2024. And then also an antimicrobial optimization workshop as well in March. So I'm sure they'll be great. And yeah, so just thanks again everyone for joining, and I'll let you enjoy the rest of your evenings or days, depending on where you're in the world. Thank you.